Welcome everyone again to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences, in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, you can enter those in the Q&A box anytime you feel comfortable. Do know that we do hold questions until the end, and oftentimes it is not possible for us to get through all of the questions. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly. If you are pursuing APA continuing education credits, the link to the survey that you will complete for your credits will also be in the chat box, but near the latter parts of the presentation, near the top of the hour. So keep your eye on the chat box for that link near the hour. Make sure you bookmark or otherwise copy and save that link before the webinar closes, and make sure you save a copy of your completed certificate after the fact. If you missed last week's talk in the series, Dr. Karen Reimer's discussion of geriatric forensic evaluations is now available on our YouTube channel. A recording of this week's talk should also be available on our YouTube channel sometime later this week, and a version of PowerPoint slides for those that have registered for the series will be available later this week as well. Lastly, as a heads up, next week we have Dr. Tatiana Matlis who will be discussing the role and relevance of cognitive testing in forensic evaluations. But circling back to this week, I'm very excited to introduce you to today's speaker, who will be discussing a structured approach to addressing ethically questionable conduct by forensic colleagues. This is Dr. Tallie Armstrong. Dr. Tallie Armstrong received her doctorate degree in clinical psychology from Sam Houston State University, completed her internship at Eastern Virginia Medical School, and postdoctoral fellowship in forensic psychology at MUS, Medical University of South Carolina. Dr. Armstrong is a licensed psychologist in Virginia and Massachusetts and through SIPACT, who obtained board certification in forensic psychology in 2024. Her professional career centers on public sector forensic evaluation work and developing research infrastructure for large organizations. Her private sector work focuses on civil forensic evaluation work with families and juvenile forensic evaluations. She's currently a forensic psychologist and chair of the IRB for the Virginia Department of Behavioral Health and Developmental Services. Her research interests include quality of forensic report writing, disseminating information about forensic assessments and strict security settings, and the impact of ethics and artificial intelligence on forensic psychology. In other words, making the practice of forensic psychology a little bit better than we have it currently. So, Dr. Armstrong, Tallie, on behalf of the University of New Mexico, thank you so much for joining our series, and I know we're excited for you sharing your expertise in this area with us today. And I'll go ahead and throw it over to you.
Thanks, Anthony. Before we get started, just a couple of housekeeping issues. I don't have any financial arrangement related to this activity. These are my views and the views of my colleagues, not necessarily those of UNM. And I want to highlight today that we are going to be using a vignette for this presentation that is based in true events. And so any accuracy to actual events that have taken place in elsewhere is purely coincidental. Okay. But it's really great to be here today. Anthony, thank you so much for inviting me to give this talk today. I'm really excited to walk you all through a structured approach to responding to ethically questionable behavior that we encounter in our field. I am going to attempt to use Slido today, so please have your phones ready. So if any of you have encountered an ethical dilemma in your career thus far, you'll probably resonate with me saying that it's rarely as straightforward as the examples that were given in the trainings that we've all had to take. So the data sheet that is designed with me and my co-creators kind of kept that in mind, and we're really hoping to give you all a practical way to organize data around ethical conundrums that we experience with our colleagues and that we can use to come to a resolution that is authentic to us and to the way that we perceive the situation. But before we get into the vignette, I want us all to be on the same page about the definition of ethical decision-making and how this organizational document came into existence. So there are many ethical decision-making models that exist, and they often involve gathering data or information, considering internal and interpersonal relationships, various perspectives within those, deliberating the data that you gather, and then predicting outcomes. What is less clear from those models is how we organize or make sense of that data to come to a conclusion, again, that's authentic to us and to our perception of the situation. And one thing that's important to point out is that applying these base models can be particularly challenging for us as forensic professionals because ethically questionable conduct among our colleagues represents a distinct type of ethical dilemma and therefore a distinct type of conundrum. But I also want to make sure that we're on the same page about what do I mean by ethically questionable conduct? We define that as concerning conduct by another colleague that does not clearly violate ethical standards or guidelines, although ultimately it may, right? When I say forensic colleagues, I mean forensic researchers, anyone who's in training at a forensic specific site, psychologists who apply specialized psychological knowledge to the law. I want to highlight that one of the reasons that it is unique to our field, there are many, I don't have time to get into all of them today, but we are a small field. We have lots of dual relationships among ourselves, and it's unknown how frequently these ethically questionable behaviors are occurring. Although from sample data that we've got from doing similar talks with other groups of people, it would suggest that it's a lot more prevalent than we might think. And we've all probably gotten some guidance during our graduate or subsequent training on how to handle ethical dilemmas generally, but we rarely get guidance in how to resolve ethical dilemmas where the area of concern involves our colleagues directly. And that's because we have a lot of distinctive factors to consider when we're faced with these kinds of scenarios. For example, does it matter if we are the target of the conduct versus a supervisee? How often do we consider the role of emotionality in our decision making? What are we doing when we have concerns about potential consequences that could arise if we take action, positive, negative, or if we do nothing? And so ultimately, a lot of us end up feeling stuck because it's the process of arriving at an outcome that can feel the most challenging, and for good reason, as some of these questions might attest to. And so also complicating this process even further is what we perceive to be some myths around these dilemmas that are very important to address before we get into the vignette, right? It can be really easy in ethical dilemmas or when we're confronted with ethically questionable behavior of our colleagues to demonize the transgressor. And it's important that to the extent possible, we see them as a human being who may have simply made a bad decision. A lot of times when we are encountering these scenarios, we assume or believe that the only acceptable outcome to a particular dilemma is accountability for the action or for the transgressor. And it's important to remember that there can be other goals for taking action, like preventing future harm by enacting policy change where you work, or making a culture generally less tolerant of unethical conduct or ethically questionable behavior. Another thing that we want to make sure that everyone is on the same page about is that resolving these kinds of conundrums authentically involves balancing one's perceived professional obligations with one's personal welfare. And sometimes no action is the best option because it preserves your sense of self, and that is sometimes the most important thing. Also, there's rarely such a thing as like a linear dilemma. A lot of ethical dilemmas used for training involve a relatively linear issue. Oh, that's clearly unethical conduct, ergo here is the clear, ethically appropriate solution, right? In real life, as I think some of you probably have experienced, when you are faced with like a true ethical dilemma or a true conflict, it is the norm rather than the exception for it to feel very complex. And that's, accepting the reality that it is. Another thing that we want to mention is that we're going to talk about harm when we work through this organizational data sheet. What does harm mean? And harm can be broad, it can be direct, it can be latent. It may not be about perceived harm to you or maybe to another individual, but it could also be about perceived harm to, say, coworkers, or maybe to your family that you have to provide for, because if you are retaliated against, then your family may suffer the consequences of that if you happen to lose your job. Another thing that we also want to point out is that even if, as you work through this worksheet, right, or as we work through this vignette today, if the misconduct is substantiated, inaction may still be appropriate, even if the misconduct is clear, because maybe your mental health requires no action be taken, or because retaliation is a reality and you want to preserve your livelihood. And sometimes substantiated misconduct may not always result in a licensing board complaint, as informal resolution is a really nuanced concept that's not fully or well explored in the literature. And you'll see that a little bit, I hope, when we talk about response options as part of the organizational sheet that I'm going to show you. So Wow, that happened really fast. But anyway, we're going to do the Slido right now. And so I'm hoping that folks can get the QR code up or join and give some answers to this particular question. If it's working well, it should show up in real time. But if not, then it was a nice try on my part. Okay, wow. So would you look at that? Okay, we're getting some different data here. I'm going to give it just a second more, but I hope that this highlights for folks that at least in our field specifically, we are seeing a relatively high prevalence rate. And so hopefully, again, this is going to be a really helpful talk for those of you today who have maybe experienced this kind of conduct and are hoping for a different way to problem solve around it. Okay, so to help with navigating the complexity of this kind of decision making, my co-creators, Heath Hodges, Betsy Hunt, and obviously myself, created a data sheet that we can use to help us arrive at a course of action, or maybe not, when faced with an ethically questionable scenario, and that response is authentic to us and to our perception of the situation. I will say that this data sheet is still in development because it's tethered to an ethical decision-making model that we've also created to help navigate these types of situations. Heath and Betsy recently did an 8-hour workshop for this, for the AAFP series in Chicago in April of this year. I only have an hour with you guys today, so I'm really hoping that helping folks see the utility of this data sheet is going to be the best use of our time together. I also want to thank the focus group participants who participated in our discussion so far and helped give shape to some of the sections of this document that we've put together. So thank you to everyone that I've already mentioned. Okay, so now we're going to get to the fun part. We're going to work through the vignette. But in order for this to work, I really need everyone in the audience to be willing to engage in a little bit of role play, because this is really going to work as long as you're willing to play along. And so what that means is I need you as the audience member to do your best to step into the viewpoint of the person who is confronted with the issue in this story that I'm about to share. And again, as a reminder, this is based in true events. So please be mindful and respectful that others may have encountered a similar scenario, even though that any kind of replication is unintentional. So here's a quick infographic for the setting of this dilemma that we're going to work through today. It's a forensic psychiatric facility with an APIC accredited internship. You and Dr. B are the main supervisors for this internship. Dr. B does all of the forensic treatment supervision. You do all of the forensic assessment supervision. Above both of you is Dr. A, who's your all supervisor and the director of the psychology department there. And so again, remember, in order for this to work, I need you to immerse yourself in this role right here. So what is the story? Okay, halfway through the current training year, you notice one of the predoctoral interns is struggling. They are unprepared for supervision, they're asking for supervision with treatment-related tasks, and they're falling behind on the assessment-related tasks you have assigned to them. You know that the intern is competent, but there are facility policy / APIC internship guidelines that require performance improvement plans in this instance, okay? So you bring your concerns to the intern, you offer support and explore their change in performance, and then the intern bursts into tears and says that Dr. B has been absent for most of the training year. And very reluctantly, they explain that they fully represent psychology within the treatment team that they're on, and they facilitate all of the group and individual therapeutic activities without any oversight from Dr. B. You wonder if the other current intern has had the same experience. Now we're going to pause. Okay, I'm hoping or imagining that this story is raising some red flags with folks. And so usually when we participate in ethics workshops with vignettes, we just get presented with like this and this set of data alone, right? The problem, and then we're supposed to come to a solution. I imagine some of you at this juncture might be saying, well, go talk to Dr. B, go straight to Dr. A. Some of you might be saying, I need more information. Like, how does Dr. A not know what's going on? So those are all relevant. We're not going to worry about that for right now. I want to see how we do as we try to fill out this data sheet together. Okay, so here's part 1 and part 2. So first, what do we mean by duty? Let's get on the same page what we mean by that. So me and my co-creators mean that duty is the professional obligation to respond. That professional obligation can come from one or multiple sources. It might come from being part of a workplace contract, policy, by legal mandate, having direct knowledge of some kind of ethically questionable behavior, or by having a supervisory relationship, like in this instance. And to be clear, assuming duty is not the same as having a professional obligation, right? You can see down here, right? I'm not professionally obligated, but I'm choosing to involve myself, right? That is when you are voluntarily taking on going through the data sheet or kind of working through the dilemma to come to a conclusion that you feel is authentic to the situation and to you. And so here, we would argue that there is a clear duty because you have a supervisory relationship with this intern and you are responsible for their well-being. Even though you're not their treatment-related supervisor, you are their supervisor, so the duty exists. So now let's move on to what are some of the qualities of the conduct that are questionable that we would fill in this blank space in part 2. Okay, so initially, this seems like pretty easy to fill out. The intern has received, at least by their account, no treatment-related supervision from Dr. B. That might be why they're coming to you. They have told you that they're basically performing all of these duties independently. It's not really clear, but it's assumed that there's no oversight of their clinical notes that have been entered into the electronic medical record. It's unclear if the current intern has also been affected. And so initially, we would say that the intern was the most directly impacted individual, right? This problem has been occurring for at least 6 months, so far as we know, but it could be going on for longer. And so the only things that we know right now in terms of like frequency, persistence, or duration is that this has been happening for at least half of the training year. It's also unclear how long Dr. B has engaged in this behavior or whether others have noticed this particular behavior. So if we were to fill it out, this is kind of what it would look like, right? You have a supervisory relationship. There's your professional duty. Here's some of the details that we've already gone over. This is what this might look like. When we say persistence, in theory, this kind of relates to the conduct itself, but it could also pertain to if it has been persisting for a long period of time, does that have implications for the potential transgressor, right? You could also put data in there if you wanted to, or if you thought that that was helpful. And so again, the truth is that when we're confronted with these scenarios, we might feel like, okay, now we have enough information to make a decision. And maybe your initial thoughts regarding what action to take, in spite of having this filled out, haven't changed that much. But what we know is that, again, these types of scenarios don't occur in a contextual, emotional, or cognitive vacuum, right? In real time, we have all of those things happening all at once. And so now I'm going to give you guys some more information that really gives life or shape to those other contextual factors that really make navigating these decisions difficult and having an organizational tool really important. Okay, so now let's imagine that with more information, it's not just that you're working at a forensic psychiatric hospital and you're a forensic assessment supervisor, but you're also an early career professional, right? You're less than 5 years out of completing your internship. And you happen to be working where you completed your pre-doctoral internship. You feel really excited and happy to be working at the facility. You think the environment is collegial, cohesive, it's professional, and you have positive working relationships with Dr. A. Dr. A is obviously the psychology director again. They're mid to late career. They have many years of forensic experience. They have a positive relationship with the department, or a positive reputation at least. And then we have Dr. B, who is not only mid-career, but they're also board certified. You enjoy working with Dr. B, although you don't see them very often. And over the time, so like since you started working at the hospital post-internship, you see even less of Dr. B, but you, again, attribute that to kind of everyone's burgeoning caseload, right? It's a forensic hospital. We know that our caseloads are high. And you remember that when Dr. B was your internship supervisor, that Dr. B wasn't always available for supervision during your training year, but that Dr. B instructed you that this was part of learning to function as an independent psychologist. And so you ostensibly never had any issues. So you decide to ask the intern some more questions, right? Let's say they tell you that they and the co-intern assumed that everyone, so all of the working professionals within the department, knew of Dr. B's behavior, and that interns from previous cohorts had had the same experience with Dr. B. Okay, so Let's say you also decide to review the internship handbook and the department policies, and you find out that supervisors with trainees under APIC approved internships must have at least 2 documented hours of supervision per week. You ask the intern what kind of documentation they have for Dr. B, and the intern tells you they have no way of documenting supervision hours with Dr. B because supervision has never occurred. So you have good relationships with Dr. B and Dr. A, right? As we learned earlier. So you decide to speak with them about this issue. You try to get in touch with Dr. B over the next week. So you try to email them, you try to call them on the phone, you do impromptu office visits. All of that is unsuccessful. You feel really frustrated and slighted by Dr. B's absence and lack of responsiveness. And so you decide to go to Dr. A. So Dr. A's response is less than positive. You point out the potential consequences of the situation. The intern is clearly struggling. They may ultimately fail internship if they don't get the situation remediated. There's also the issue of not following through on APIC standards. And Dr. A responds, well, the intern is getting supervision from you, and you don't have concrete proof that Dr. B wasn't doing their job. So, like, what's the big deal? And they say, I guess you should just put the intern on an improvement plan. We don't want APA to revoke our accreditation. You protest this idea. And Dr. A insinuates that you aren't able to truly appreciate the nature of the situation because you're an early career professional and you're not board certified. So at this point, the conversation ends. You feel very convinced that any further discussion will worsen the situation. You yourself might be subject to negative performance reviews because you're not being receptive to feedback, or at least that's how it's being perceived by Dr. A. And you might inadvertently cause some real negative consequences for the intern. They may ultimately fail internship, or there might be some concerns about retaliation. And due to the positive reputation of Dr. A within the department, you worry that your coworkers might not believe you or take your concerns very seriously. And so you leave the whole experience feeling very, very uncertain. So now we need to make some adjustments to our worksheet, right? Not a lot, but I think some. And right now, we don't have a lot of firm data about what the intern is saying and how true it is. But what we do have should be concerning, I hope, to all of us in the audience. A lot of the trainings, again, will have us kind of stop here and make a decision about how or whether to act. But stopping here is really not being thorough and not giving voice to all of the contextual factors we know are part and parcel of these kinds of ethical conundrums. In addition, because we have an established duty to respond to the situation in our role as supervisor, we're going to keep going through the worksheet and kind of digging and working through this issue. And I also want to highlight this particular piece as an example that the data sheet does not have to be filled out as like a one and done sort of thing. As you continue to problem solve the process, more information may come to light, which you then would have to retool or re-enter into the data sheet, and that may ultimately help you with your decision-making process. So it's not designed to be like a static document. It's designed to be a kind of a living document that helps you all the way through to the end. So here's where we're going to start to catalog the evidence that we have at this point in time, right? We think about sources, right? At the top there, we have the intern self-report. We think about limitations to that data. It's really just the intern self-report, right? We want to think about what might be other data points that we would want to pursue to help us kind of understand what's really going on here and how potentially problematic this is. One is that we might want to talk to the other current intern and get their sense of things. We may also want to get reports from the previous internship cohorts to see if what the current intern is saying is true, right? That this has been a pattern of behavior. You yourself experienced it, but it wasn't particularly problematic for you. And we also might want to get Dr. B's commentary since they haven't responded to any of your attempts. In theory, you could continue to go back to Dr. A, but you may decide against it because the first encounter was like so dissatisfying and very uncomfortable. Then we want to think about what kind of harm may have already occurred, what might occur in the future, and what could have already occurred in the past. And that's important because sometimes it's easy for us to think about what is the harm right now or what is the harm in the future. And we don't often think about if this is a behavior that's been going on for a long time, what kind of harm might have already occurred, okay? One thing we want to point out is that other interns and patients could have been affected. The current intern and their patients are arguably being affected right now, and future cohorts might be negatively impacted if no action is taken. So if we were to fill out the data sheet, this is what we're thinking about, okay? And then here, I put this checkbox, not necessarily because it's the way, the truth, or the light, but to just give you guys a sense of there is a little bit of subjectivity here because, again, we want you guys to feel authentic in your responding. For people who are really data-driven, these data points may not be enough, and they may want to seek out more data before they make a decision. For other people, they may feel like this is relatively strong data in and of itself to take some kind of action, right? So when we give an appraisal of the strength of the data, this is a very individual decision. We would argue that the data are lacking in corroboration, but that doesn't diminish the potential egregiousness of the conduct, especially if we consider the context of the actual or potential harm. Okay, so if past interns were not getting adequate training, patients may have been inadequately treated, right? This is a forensic hospital, it's a forensic population. These are particularly vulnerable individuals, which could raise the perceived egregiousness of the conduct, whether it's past, current, or future. And again, if we're thinking about like the ways that we've been taught to conceptualize ethical dilemmas, we again might be tempted to stop here and kind of shortcut our decision making and move to action steps. But again, we're not being mindful of all of those other contextual factors that have been brought into play. And so again, this is where the data sheet is really important because it's going to give shape and voice and structure to all of those cognitive and emotional and real life factors. But before we get to all that fun stuff, I want to make sure that we spend some time talking about applicable standards. And so this space on the data sheet is where we give more concrete parameters to the something's wrong, but like what is wrong? And this is the space where we can anchor the behavior to a specific violation if it's anchorable in that way. And doing so can be really helpful for us in differentiating behavior that just like feels icky from behavior that is actually unethical according to some kind of professional standard. Sometimes the icky behavior is enough for us to decide that taking action is necessary, but that action may be fundamentally different from whatever action we decide to take if we determine that that icky behavior is actually tethered to something that's an enforceable guideline or statute. And so this is not an exhaustive list, but this is what we have put together as standards that can help give shape to these issues. So here we don't have any information about whether reporting is legally required, although some states do have that put into their statutes, so we would encourage you to review those. You may also want to review the ethical principles and code of conduct. Sometimes people think that that's the only place that you have to look. We would argue no. You can look at the specialty guidelines. You can look at workplace policy. Sometimes the Better Business Bureau has codes of conduct that you can look at. But for this particular scenario, we want to think about, right, workplace policy. That is clearly outlined that there are certain things that have to be followed. In this case, we also have APIC accreditation guideline, like certain numbers of supervision hours have to be met every week. And then possibly the ethical codes of conduct. So let's take a look and see how this kind of gets filled out. Let's see. Okay. So we look, possibly we may have a violation of 7.06 in terms of assessing student and supervisee performance, right? It relates to establishing timely and specific process for providing feedback. Psychologists evaluate students and supervisees on the basis of their actual performance. And then we have workplace policy, right, regarding documentation of hours. Sounds like the facility adheres to the APIC guidelines, and so failure to supervise could result in termination either for the trainee, the supervisor, or both. APIC criterion 7 may also be applicable here, right? Failure to adhere to the X number of supervision hours per week can result in loss of accreditation, among other penalties. Okay, so these are things that kind of are giving shape to, it's not just icky, but like, is there something enforceable about the icky behavior? Now we want to take a look at the impact of relationships, right, between you and Dr. B and Dr. A. Does it matter that one of them is board certified? Does it matter that one of them is your employer and you fear possible retaliation? I think arguably the answer is yes. I think those things do matter. And certainly when we were creating the ethical decision-making model and talking with our focus group participants, relationships were a constant thing that came up, and how do we navigate that? So we want to give space to talk about those things. Okay. So again, who's the responder? That's obviously you. Who or what are the professional wrongdoers? We have Dr. A and we have Dr. B. Sometimes it's more than one person. Sometimes it's just one person. Okay. What do we know about Dr. B and Dr. A? Right? These are the things that we've already talked about. These are well established in the vignette. In terms of relationships, no ostensible personal relationships, at least from what we know about the vignette. We know that Dr. A was a former supervisor when you were on internship because they supervised Dr. B. They're your current supervisor and they hold some employment sway. They're well liked in the department. Dr. B, former supervisor, current coworker. So if we were to fill this out, this is what it might look like. Again, imagine yourself here if we're thinking about perceived personality traits. And here's what I mean by that, right? When we think about perceived professional influence, this doesn't have to be totally reality-based. It's just your perception. Reality testing can come later. But right now, what we know is that Dr. A has significant local influence because they're well liked within the department. We're not really sure what Dr. B's professional influence is, other than the fact that they're board certified. We don't know how well they're received in the department or within the forensic community generally. In terms of personality traits, Dr. A was ostensibly invalidating during the conversation, and Dr. B is just unresponsive. There could be more there, but that's all we have. We don't know any kind of misconduct or filing history, but that is important to keep in mind because if you are confronted with a scenario where you have someone that you know has a very litigious history, that is certainly going to inform what kind of action steps you take or what you feel comfortable taking. Right? You don't have any misconduct history, right? Your own experience as an early career professional, you might have some influence at work, but at the national level, right? Nothing really in the vignette that would give us any indication that you're at the national level, at least not yet, right? Okay, so now this is where we talk about like, what do we think might happen? And so what's important to keep in mind is that this is going to be very much influenced by you in the situation. And here you can see in the box where it says, if you take appropriate action, right, in all three of those questions. When we talk about appropriate action, that's the action that you believe you must take because of some kind of obligation or overarching policy or code to follow, and or you perceive that there might be an appropriate action to take, and whatever that is may or may not align with like the actual standards that you've identified a couple of slides beforehand. What is important is that we focus not just on our feared negative consequences, but on what good may come from us taking some kind of action, in addition to what might happen if we do nothing. Remember, doing nothing is a legitimate option, especially if, for example, your mental health is vulnerable. When we talked about creating this model and when we have talked to our focus group members who have confronted ethically questionable behavior, sometimes there was no action taken because mental health was a real concern, or there was a legitimate concern of retaliation or losing one's job. Right. And so that's why we call this section, again, perceived consequences, because some of these consequences may be legitimate and some may ultimately be less legitimate after you engage in some reality testing. So let's get into the data that we have here. Right. We already have some sense from the story. We might fear negative consequences for the intern. Right. That came out during the conversation with Dr. A. Maybe some concern of poor performance review. If you want to catastrophize that, maybe that is fear of losing one's job. Potential disapproval from coworkers, right? There was some concern about not saying anything to the coworkers because Dr. A has a good reputation in the department, and vocalizing this would go directly against that. Let's think about positive outcomes for a second. This part's going to be really individual. So again, this is not considered the way, the truth, and the light. This is just giving some examples to fill it out, right? Important to consider. What might happen if we take no action? Again, it's a legitimate option, but here's what it might look like filled out, right? So for this particular individual, maybe they're very invested, or maybe you as the responder are very invested in protecting others from harm. Maybe for some of you, you just want a successful informal resolution. Maybe you want to create a safer environment from future ethical dilemmas, right? What we do know is that if there is no action taken, there could be continued harm to others, if the cycle perpetuates, especially if you're able to confirm that this has been a pattern of behavior across previous cohorts. You could be perpetuating a culture of silence or approval. And worst case scenario, the intern might fail internship, or you yourself might get a negative performance review, okay, or worse. Okay, so this is always a really fun part. So as you are kind of working through this with me, what emotions might you be experiencing as the forensic supervisor in this situation, like as you're trying to figure out how to resolve or how you actually feel about these kinds of like scenarios as they're coming up? I love word clouds. This is great. So these are a lot of really common words that we see come up when we talk about these dilemmas, when we've done focus groups, and these are all legitimate. Like if you are legitimately faced with this ethical conundrum, all of these are potential and legitimate and totally viable. And they should all be documented on the next page, right? So thank you to everyone who's responded so far. I do want to be mindful of our time. So I am going to keep going, but definitely keep responding because it will show up in the Slido word cloud elsewhere, okay? So all of those emotions should be showing up here. And we know from our training that biases and distortions are very important in our decision-making as humans. Dan Murray and Tess Neal have done a great job of discussing how biases and distortions can influence our forensic work. So it's a logical extension that we would see these biases and distortions relevant in how we resolve our ethical dilemmas with colleagues. We also know that emotions play a significant role in any decision-making that we engage in as human beings. So again, a totally logical extension that emotions would be at play for resolving these dilemmas, as the word cloud just showed us. So oftentimes it can be really hard for us to name all of those things, but it's really critical we do not ignore those factors. If you guys noticed in the word cloud, there were a lot of really negative worry-related emotions, and that can be significantly impactful in the decision-making that we engage in. So the first job is to name it, and then you can figure out how to resolve it, okay? So if we think about distortions, one really important one is that you yourself were a recipient to some extent of Dr. B's behavior, right? Whether or not that actually impacted your performance as an intern is questionable, although you became the forensic assessment supervisor, maybe not so bad. But it's still a bias / distortion that you have to contend with, right? Dr. A tells you that you don't understand the nuances of the situation because of your status, and you also are worried that your coworkers might not believe you if you say anything. In terms of emotionality, these were some that were specifically named in the vignette when I read it out loud, but all of the other emotions that were named in the word cloud are perfectly legitimate and would have a home here. So if we are going to fill this in, this is what it would look like, right? Uncle George's pancake fallacy is like the Paul Nealism that relates to you were a recipient of Dr. B's behavior and it didn't impact you, so like why is it a problem for the intern? That's really what I'm getting at here. We also have, again, being an ECP diminishes your argument. So again, it's not just about biases or distortions that you yourself are experiencing, but that you may perceive others or that you have been told that others feel about the situation who are directly involved, right? And then obviously I clicked all of these, but this is again, not an exhaustive list and could change over time. All right, so we don't know much about the respondent in this scenario, so I really need you all to put yourself in the shoes of the respondent and think about what other relevant factors might come into play here. These are designed to capture life factors that might significantly impact your decision-making that we often forget about, right? So what if you're an ECP with a new child and you're afraid of losing your job? What if you just exited a major depressive episode and you're having to cope with this kind of stressor? What if you identify as a Black woman and Dr. B is also a woman? Or what if Dr. A is an older white man and you are a Black woman? What if you previously encountered an ethical dilemma in another situation and it went poorly or you experienced retaliation? Could that significantly impact your likelihood of wanting to do anything or what kind of action you ultimately do take? It sure could. What if you find out that Dr. B has terminal cancer and that explains their absence, right? Those are all things that could come into play here that could significantly impact what you decide to do. Before we move on, I do want to highlight that we have paranoia in here, but that is not clinical paranoia associated with like a psychotic disorder. What we mean here is giving voice to that really real sense of anxiety and hypervigilance that you can experience when you're having to navigate these kinds of ethical dilemmas. You feel like everything comes back to the ethical dilemma, all of the what ifs that are involved in it. And so there can be a real sense of like kind of cognitive spiraling and emotional spiraling, and that can result in this like pervasive feeling of kind of hypervigilance or paranoia. So we're giving voice to that experience for folks. Okay, so navigating these scenarios can feel like an extremely isolating experience, despite how prevalent these experiences are. So it's really important that we give space here to consider and to help you consider who you can connect with to feel less alone in the decision-making process. But we also want you to be smart about it, okay? So this is a great space for you to explore where you can get some reality testing, where you can get some validation, or general feedback to help you with this decision-making process, especially if you are recognizing, for example, that you have high emotionality tethered to the situation. There's some significant relationship factors potentially impacting the situation, whatever, okay? So here in this scenario, perhaps, maybe there are other coworkers at the facility that you could go to get some consultation. Despite Dr. A's good reputation. You could also speak with colleagues external to the facility, right? The vignette doesn't explicitly specify that, but that's a reasonable conclusion. A lot of people have talked about recruiting folks outside of the forensic community. Sometimes that feels safer. Someone that you trust who has a, I don't know, for lack of a better term, good head on their shoulders. This is a typo. I know it's a typo, but we're gonna ignore that. But if we were to fill this out, this is what it might look like. Some people feel more confident or comfortable speaking to like the trust or an advisor with the state licensing board. Sometimes it might feel necessary to retain legal counsel, right? Whatever. But again, this is just an example of how we would want you to fill this out so that you can give some consideration to how to resolve the situation so you don't feel alone. Okay, so here we're kind of at the final piece, right? What do we do? We've gone through this data sheet, we've filled it out. Like, what's the action going to be? What options are available to me? You can check more than one box. Multiple can be implemented at the same time, right? And so this is where you get to kind of take all of the data that you put into the data sheet and try and distill it down to a series of action steps that feel authentic to you and authentic to the situation. And remember, no action is still an option, and it can be a very legitimate option. So if we think about this scenario, what would be relevant here? We know that at least up until this point, we've tried to email, call, or do impromptu in-person visits to Dr. B. That was unsuccessful. So then the question is, well, do you keep going, right? Do you stop trying? You want to document that you made the attempt, but you get to decide if you want to keep moving forward. Then we could document that we tried to have an informal meeting with Dr. A. That did not get resolved, or it didn't get resolved well. So could there be a next step beyond that? Also, we want to keep in mind that the way that we appraised the strength of the data earlier in the data sheet was that we decided it was somewhat lacking. Would have been nice to have a few more data points to give more shape to maybe the scope and prevalence potentially of the harm or what actually was going on. So if we were to fill this out, this is what it might look like, right? Here's all the things that we've tried with Dr. B. We may or may not decide to continue to try those things. We also tried this with Dr. A. You might want to put a separate scribble in here like perceived it did not go well. You could then decide to coordinate some kind of mediation with HR, especially if you're significantly concerned about potential retaliation against you or the intern, especially if there might be a performance review coming up. In terms of others here, again, this is not the way, the truth, and the light, but might be dependent on some of the other data that you get, but talk to the current and former interns. You could notify APIC or APA of a possible violation. Because there was a potential ethical code violation, you could submit a licensing board complaint here too. Maybe you decide to actually file a licensing board complaint, but you do it after you leave the job because maybe the job is actually really toxic, right? Again, I'm throwing in hypotheticals that are not included in the vignette, but again, are very possible to occur in real time, and that can definitely and legitimately impact what kind of action you decide to take, ultimately one way or the other. Okay, so I can't believe it. I actually left enough time for questions. I thought I was really going to run up to the end. So if you want a copy of the data sheet, please email me or my co-creators. Remember, it's in development, so this is not a finalized document. We aren't billing ourselves as ethical consultants, but if you have a question about how to fill out the data sheet, we can absolutely help with that. If you're interested in learning more about the model behind the sheet, we'd be happy to talk with you more about that too. Thank you all so much for your time today. I hope that this was a helpful and valuable experience for those of you in attendance.
And thank you so much, Dr. Armstrong, Tallie, for the work that you and your colleagues are doing in this area, for all the practical considerations that are going into this sheet of how this will actually translate into practice beyond more of the intellectual exercise of ethical decision making. I could see a lot of engagement here, and I'm sure everybody, many have benefited from this. I will disclose right now that near the end of the talk, I got kicked off of the webinar and popped back on. And apparently that means I cannot see any of the past questions. So I do have questions after 11:45 our time and can start with those. I would encourage people that have entered questions earlier in the talk that would like those answered. If you could enter them again, or if you best you can remember, that would be greatly appreciated. In the meantime, we do have a number of questions here already, and the QR code for the survey is up currently right now. I'll read questions that I have in the meantime right now. Somebody asked, are there situations where legal or license requirements impose an affirmative duty to report and no action is simply not an option? How would you navigate that?
So in those scenarios, again, that really is where we encourage folks to become super familiar with their state's administrative or enforceable code under the licensing board. So I know there are certain states that have very explicit mandated reporting for, like, for example, if there's like fraudulent behavior. We could also think of the like sleeping with your trainee trope or sleeping with the patient trope. Like, there are some states that have that very explicitly outlined. So that's really the first place to start. And then you kind of work in a top-down fashion. You might be able to find some documentation in terms of like what you're contracted to do. Like if you're a contractor working for an agency, there might be a requirement in the contract to report certain types of conduct, and you can't get out of that. Your workplace in particular may have very explicit guidelines around how to respond to certain types of conduct. So there's certainly no harm in being very educated about what the rules are so that you have some directionality if the rules happen to get broken.
Thank you. Somebody added, first, thanks for such a thoughtful presentation. And they wonder if you can explain if there's any basis in EPPC for tolerating unethical behavior because it could have an impact on you professionally.
I think I kind of understand the question, but if it's possible for them to elaborate a little bit more, like, I'm not sure if that's like, maybe I need to scroll down. If there's any basis.
11:48 timestamp.
Yeah. Oh, okay. So Ira, is that because you're concerned about like someone not wanting to have a response because it could have an impact on you, like you could be retaliated against? If that's what you're getting at, then yes, like that's why we provide a lot of avenues during the data sheet to say, like, maybe it's actually not a safe time for you to take any kind of action because there's a legitimate concern that anything bad could happen to you. Another way that I might interpret this question is like, could you yourself be ethically liable? I mean, I think it's plausible, especially if there's like an established duty and that duty is considered to be violated. But again, it's kind of like on a scenario by scenario basis. Like let's say APIC later found out that this behavior had been occurring and it was substantiated. You knew about it and did nothing. I think arguably APIC would have grounds to do something about that. But depending on the contextual factors, right, if the environment is legitimately toxic and you didn't feel like you could do anything about it, hopefully APIC would take that into consideration. But again, another reason to maybe have this data sheet to kind of work through all of those possibilities to help you arrive at a conclusion that feels kind of authentic to the scenario and to what you're currently experiencing.
And Ira has confirmed that you did directly
Okay.
address this question.
Okay, cool.
I'll combine two here that gets more at the potential for this expanding beyond. We focused, of course, on forensic assessment here. Someone asked your thoughts on whether this format could be used for other licensure types, like a professional counselor, social work, marriage and family counseling. And then someone asked if you had any suggestions for how to deal with ethical concerns when they involve someone who is not a psychologist, maybe a different medical professional that is in a leadership position, maybe in a similar context that we discussed here.
Yeah, I will be clear that when we created the model and the data sheet, we really kept it within the forensic community specifically because we had to have at least a starting point. Me and my co-creators are in agreement that this could have a very broad application, but we don't have enough data or kind of backdrop yet to kind of know what that would look like in terms of what nuances might you encounter in like an LMFT environment or a master's level environment versus like maybe dealing with someone who has an MD. And so I think in those kinds of individual case by case scenarios, this kind of an organizational approach would probably be helpful, but some of the more specific suggestions that we've given, like in our trainings, in the ethics model, in this data sheet, may not be as applicable and, would need to have some tailoring. But again, we can't, as creators, kind of speak to what that would look like in those other professions because we haven't tested it yet.
Any thoughts about handling multiple minor ethical violations that individually might not meet a threshold for needing to report, but in culmination are more concerning to you?
Yeah, and so so this data sheet is a great way to start kind of looking at that because that is something that some of our focus group participants did highlight was like how many times does something have to happen for it to be enough? And so that's really where kind of looking at like, well, what are the relevant standards? What are the qualities of the conduct? How long has it been going on? What's the perceived or actual harm? Like that can really help you make a decision about how many times is too many or does it have to be X number of times? And then like, once that threshold is met, then you act, or does it just have to be one time, but it's really bad, right? There's no hard and fast rule around that. And so again, the data sheet is really going to help you work through some of those cognitive roadblocks that we get into. Like maybe it has to be X number of times before it's a problem. Maybe it does, maybe it doesn't. Like the only way you'll know is if you're willing to kind of work through the data sheet and see kind of the picture for what it is.
What type of documentation would you recommend keeping as you progress through talking to the various individuals? Should this be documented on the form? Should it also be documented separately? How would you go through this?
So I wasn't able to kind of fit it into the slides, but if you look at the data sheet in whole, it's like 4 pages, and like on the back page, it's like 3.5 pages with a bunch of blank spaces. And so you can fill out the data sheet and just have like one kind of ongoing living document where you like make scratches and like make changes, or you can fill out the data sheet multiple times. You can have a separate notes section. There's no like hard and fast rule around it. But we also want to, again, keep in mind for folks that this is still a work in progress document. This is not one of those things that we can give you like recommended guidance in terms of like, if you turn this over to like an attorney, that this would be like something evidentiary or whatever. Like you would want to have more than just this, and relying on this is probably not, if you decide to take specific legal action, for example, you would want something that is a lot more robust potentially than just the data sheet. It's really just designed to help us get a sense of the larger picture, make sure that we're not being led erroneously by biases and distortions or emotionality, that we are giving legitimate weight to real life factors that could be impacting our decision making, so that we are more prone to make an objective evidence-based decision than an emotional reactive decision that we might later have strong feelings about.
And you've referenced the work on this and the sheet being a work in progress. We have several questions here in various forms that relate to can I get a copy, or how could you share this? Could you share this in the chat? The kind of things. Where are we in terms of the form and any possible dissemination of it?
That's a great question. I have to confer with my colleagues on that. I know that we've gotten requests for it on an individual basis after we've given talks like this. So I think the best thing to do is just you can throw my email in the chat, Anthony, and folks can email me as they want.
Okay, all right. Thank you for that. I will try to multitask as
Am I allowed to? Can I actually type in the chat? Because I can just put it in there. It doesn't matter.
I believe you have that. Yes. So just make sure that do you have the ability to type in the chat to everyone rather than just the host and panelists? That would be the one issue.
Yeah. Okay.
Great. Okay, there we go. Somebody said for situations that do end up with a referral to the licensing board, in their experience, they find the board struggles with handling forensic cases. In other words, if the client patient is not the one filing the complaint, they have difficulty gathering necessary relevant information to support an ethical issue. Any recommendations for conveying issues and concerns to a licensing board?
Oh gosh. I want to be mindful that, I'm not an ethical consultant, so it's going to be really hard for me to give guidance around that. But one thing that I might encourage is that filling out this data sheet may be, again, that organizational tool that you can use to help structure whatever argument it is that you submit to the licensing board to help them appreciate the concerns that you have with the conduct that you observed. I wouldn't necessarily say that it's a direct one-on-one corollary, but at least this could be a starting point to kind of help give shape to how that argument might be more effectively conveyed.
Excellent. And I know that you, in your scenarios, you discussed some hypotheticals that did involve race. And somebody asked, would you have any suggestions about how to handle this situation? Would they differ if, say, in this situation, the supervisor was Black and the supervisee was white?
Yeah, I mean, when it comes to those kinds of individual nuances, it's really about what you as the respondent feel in that scenario. As a white woman, obviously, there's only so much I can say about that. But when we have talked with people in our focus groups who identify as minorities across multiple different kind of identities, they have indicated that there is sometimes a very real impact about whether or not they choose to act because of how they are either concerned that they will be perceived by others, that they might be retaliated against, that they may not get the support that they deserve. And so we just wanted to make sure that in the data sheet that is not ignored if you yourself happen to identify with a marginalized identity, or if the transgressor or potential transgressor is identified in one of those groups. So one of the reasons I put in, would your response be different if Dr. A, for example, was like an old white man, as opposed to maybe like a young, early career woman who may also be board certified, right? Those are all things that legitimately influence, I think, the way that we engage in this decision making. And my co-creators would agree, and so we just don't want that to get ignored.
I will direct everyone to Dr. Armstrong did enter her email in the chat. So if you have any questions for her, I know she will be prepared if you are sending an email from a place that has security email. She'll get the encrypted details, but she will handle that. Dr. Armstrong, thank you so much for sharing all of this, for your contributions in this area, and for your perspective on handling these situations and talking with all of us today on these issues, particularly in a climate for you that is hot, sticky, sweet. That wraps up this week's Law and Mental Health series. We hope to see you next week when Dr. Tatiana Matlis will be discussing the role and relevance of cognitive testing and forensic evaluations. We hope to see you then for another great discussion of issues in behavioral health and the law. Until next time, take care.
Thanks, everyone.
Thank you.